Okay. Okay. Good evening, one and all. I'm Vikram Sopti from Lupin. I First and foremost, I welcome all of you for this, session on FOT. I heartily welcome our speaker, Dr. Suhas Badapurkar from Aurangabad. He is a senior consultant pulmonary chest physician. He did his post-graduation from Government Medical College, Aurangabad. He has been tutor in Department of Chest Medicine at GS Medical College. Not just various institutes and papers of which he has been publishing, he has also his name featured in the Limca Book of National Records in 2009 for holding and educating maximum more than 10,000 patients on bronchial asthma, COPD, and TB. Sir is life member of Indian Chess Society. He is member of IMA Aurangabad and is also a joint secretary of Alankar Sports Foundation Aurangabad. Uh, with all due respect, sir, I hand over session to you for further listening. Thank you.
Thank you.
I am unsharing my screen, sir.
Okay. Thank you. It gives me a great pleasure. Can you listen to me?
Yes, sir. Loud and clear.
It gives me a great pleasure to be with you all. Thanks to the Lupin for allowing me to have this important lecture on lung oscillometry in clinical or chest practice. So friends, first 10 minutes I'll roughly go through all the spirometry, lung oscillometry, what are the technical details and that. Then I'll share my important cases with you, and then you can have your cases. Then we'll have question answers. So to start with, friends, we know that doing lung function test in young children is very difficult, and at times it is impossible. Or if the child performs spirometry, it is not acceptable as per the ERS or ATS guidelines. However, this is a child who is 5 years old and gave excellent flow volume loop as well as expirograph. But you have to take a lot of efforts, particularly in doing spirometry in younger patients, as well as this is also true for elderly patients, 70 plus and so forth. So we must go for an advanced and very important topic today is lung oscillometry, why we should do it. And then what are the operating principles, what is resistance and reactance, what are the key patterns and parameters, and how can we apply this data in our clinical day-to-day practice. So impulse oscillometry or air oscillometry is the Pizzolo and colleagues showed that the almost 20% of patients between 65 and 95 years are not able to perform spirometry satisfying ATS ERS requirement. As I told you, similar is case with the children who are say 3 years to 6 years of age, and that's why or impulse oscillometry is very important. Now, if you look at chronic asthma, bronchial asthma, or COPD, basically they are predominantly small airway disease. And almost 80 to 90% of the terminal bronchioles are lost by the time the emphysema is clearly visible on CT scan. And small airway, this is very important aspect of bronchial asthma. When I was undergraduate and postgraduate student, we were taught that asthma is a disease of large airway, while COPD is a disease of small airways, alveoli, interalveolar septa. However, now we are realizing that bronchial asthma is not only a disease of large airway, but there is a different entity we call it as small airway disease or SAD. And this is seen in almost 70% of bronchial asthma patients. So doing and finding out the small airway disease is very important in patients of bronchial asthma. Now, if you look at this excellent photograph, which has been shown, which is showing the the trachea the main bronchi, then bronchioles, respiratory bronchiole, and alveoli up to alveoli. So there are almost 40,000 airways with bimodal branching pattern, one side slightly bigger than the other, and there are 23rd branching generations, and overall we inhale 10,000 liters of air in 24 hours. Similarly, lung is supplied blood, which is impure blood by heart, and that is also 10,000 liters in 24 hours. If you take out the tracheobronchial tree out and spread the bronchial tree, it will occupy a surface of 75 to 100 square meter. That is because it has to work day in and day out to purify our blood. So this is what the lung oscillometry is done. This patient is performing lung oscillometry. He has to sit on a chair or a stool, straight up, looking just slightly upward, say 15 degrees extension of the neck. Then the technician is holding the instrument with the mouthpiece in the mouth of the patient, which he has to hold it in his lips, and then he has to press his cheeks so that the cheek won't expand with inhalation or exhalation of air from the mouth to the lung. And that's why you have to put both the cheeks on both the hands on your cheek, and then ask the patient to perform simple tidal breathing. Just 30 seconds simple tidal breathing will pick up the abnormalities in the tracheobronchial tree. Here, the sound waves are passed along the tidal breathing, and when they come out, they are analyzed. That we will see later. Now, what is the principle? The sound waves are generated with the help of either loudspeaker and are transmitted to the lung of subject with tidal inspiration expiration. The sound waves are essentially pressure waves, which cause change in the pressure, drivers changes in the airflow. By measuring the magnitude of the change in the pressure and flow, one can find out mechanical properties of lung also, which is impedance, which is equal to resistance and reactance. You know, resistance we can definitely find out by doing spirometry. However, we cannot find out reactance by doing spirometry, but reactance and resistance, both these can be found out with doing lung oscillometry. Now, if you consider the tracheobronchial tree, the trachea gets into bifurcated into two right and left main bronchi, and then there are multiple divisions, up to 8th division, right from the carina up to 8th division, what we call it as large airways, which which is conducting zone. The internal diameter is more than 2 millimeters. And then from 8th generation to 23rd generation, these are all the small airways which have inner diameter which is less than 2 millimeter. And this is the acinar zone where the most important, that is gas exchange, takes place. So we know about large airways and we know about small airways. Now, what is the impulses, how they penetrate? You know, there are two types of impulses basically used, 5 hertz and 20 hertz. To be very specific, 5 hertz and 19 hertz. The slow impulses, they travel through and through up to alveoli, right from the trachea to alveoli, while the high impulse, 20 hertz, they will travel only large airways. And that's why, see, low frequency or high frequency has low penetration, only upper or central airways, while low frequency has deep penetration or total airways, central as well as peripheral airway obstruction or reactance can be measured with this. So let us know how it is done. This is a diagrammatic presentation how the patient lung oscillometry is to be done and what are the measurement sequences. Now this is the oscillometer which patient is holding in his mouth. There has to be nose clip. Both the hands should brush the cheeks, and then patient should have quiet breathing. This is normal quiet breathing, what we call as tidal breathing. And then the tremoflow oscillatory waves are over the tidal waves, and then when they come out, they are analyzed for breathing pattern and respiratory mechanics. So both of these can we do. Again, let us see. The waves are going inside and they are coming outside with the sound waves superimposed on that. So we can find respiratory mechanics, which is resistance and compliance. This is the graph what we get on air oscillometry outcomes. The upper line, it denotes obstruction, while the lower line, it denotes the denotes the reactance, particularly small airways and peripheral airways. Now R5 is the total airway resistance. R20 is the large airway resistance, and when you know that R25 minus R20 gives us a small airway resistance, which is heterogeneous. Now the lower one or negative wave X5 is the reactance at 5 Hertz, while if you trace the line, negative line from 5x to the midline, that is 0, where it crosses, that point is called as resonant frequency. This is also very important to look at, and this can give us idea about the severity of lung disease that we will come to know. And then the Goldman's triangle, particularly from X5 to a point where the reactance line intersect the central line, and then the x-axis and y-axis is the shaded area. The triangle is called as the Goldman's triangle, and it is very, very important to find out the reactance and resistance, particularly in small airways. Now, this is the only book what we are doing in lung oscillometry last 5 years, and this is the only book available in the world, which I got it from Amazon. This is Beraz, Stena, Erika G, and 1, the impulse oscillometric features and respiratory models. So this is a simple book, but it is 80% physics. I could understand only 20%. So we'll not go in that detail. So again, the tidal breathing is superimposed with the sound waves which go to the lung, and then in large higher frequency as well as shorter frequency, and then it comes out. As you know, the upper line indicates the resistance, the lower line indicates reactance. Now let us look at the respiratory mechanics. What are the basics? You know, this is the pipe compartment, as everybody knows, that this is responsible for resistance. In asthma or COPD, the pipe component is increased because there is airway swelling because of edema, bronchoconstriction, and then this is the compartment C, or which is be called as a balloon compartment, which expands resulting from the applied pressure. And this is decreased in lung disease like COPD, emphysema, or chronic bronchial asthma, or ACOS. So resistance is the positive line, R, that is indicated in the graph as a resistance line, and then compliance, particularly of it is denoted by the negative line, what we call as compliance, or C. Then lung has its own inertia, what we call I. Then the reactance line, which intersect with the horizontal line, which indicates 0, where the inertia of the lung and peripheral airway reactance are 0, that is called as the resonant frequency. So inertia is mostly I. Then the compliance is mostly C, which is negative. And then this is the resonant frequency that the midpoint. So what are the key patterns? We get normal, then there is central obstruction in normal, the resistance line is near normal, the compliance line, which is X, which is negative line, is also normal. But in central obstruction, particularly mild asthmatic, the resistance is slightly increased and the compliance is almost same, normal. While in peripheral obstruction, you get compliance as well as resistance has increased. And in severe emphysema, we know that there is dynamic collapse of the small airways and alveoli. They're both the lines. The resistance line goes up as well as the compliance line goes down and down. So let us find out. These are the parameters. Now, most important parameters, as I told you, 6 important parameters of the 4 parameters are given here. So when it is normal, R5 is normal, R5 minus 20, that is small airways, are close to 0. AX is normal, X5 in expiration is close to 0, so everything is normal. Now here, only R5 is increased, and then rest of R5 minus 20, AX, X5 in inspiration is normal. Now here, particularly the peripheral obstruction, what we get in COPD, R5 is increased, X5 is the downward is also increased, and this is slightly shift of the peripheral airway reactance line to more negative side. And the dynamic collapse, what we get in severe emphysema or COPD, the resistance line goes up, then the R5 minus R20, which indicates small airway disease, that also goes up. The AX also increased, and the X5 in expiration, that also goes more and more. So these are the key patterns with these 4 important parameters looking into the consideration. Now, outcome parameters are that the positive side upward line is resistance. This is low frequency resistance. R5 is total through and through airway, complete airway resistance. We can find out if we look at R5, then the mid R20 is the mid frequency resistance, which indicates the large airway obstruction. And then we have what? R5 minus R20, which is more heterogeneous. As you see, there are a lot of variations, and this is heterogeneous. It indicates small airway obstruction. And then we have a negative line, that is X5, that is compliance or small airway obstruction plus reactance or compliance. Now this is small airway obstruction. The resonant frequency, look at resonant frequency. We can also get idea about the small airway obstructions. These are all the 5 important things. I will again repeat: R5, R5 minus 20, R20, X5, and then resonant frequency, which also indicates small airway obstruction. Now, most important thing is AX or Goldberg triangle, which indicates the small airway obstruction and also reactance. So these are the 6 important things you have to remember. And out of this, if you look at the small airway, there are only 2-3 important things. Look at R5 minus R20, which is heterogeneous, and look at AX, which indicates small airway obstruction and reactance. So this is the graph. Now the dark blue graph is the before giving bronchodilation, and the light blue graph is after giving bronchodilator, as what we do in spirometry. So the upper line indicates obstruction, and there is quite change when we give bronchodilator aerosol. It comes down, gets shifted to lower and lower side, and almost nearly normal. While the reactance line, which is more negative initially, that is before bronchodilation, comes up, and that's why that indicates the small airway obstruction. And the point here is the resonant frequency, that's what I was talking, that also gets shifted from left to right to left. If we trace out this will intersect probably here, that is resonant frequency, and which gets shifted to left side. So that also indicates the good airway bronchodilation. So reversibility R5 is almost 48%. This total airway resistance is 48%. R20, which is non-airway, reversibility is slightly less. It is only 23%. R5 minus by 20 is 75% improvement. So small airways have improved by 75% after giving bronchodilator aerosol. AX has improved tremendously, it is 79%, and X5 has also improved, that is shifted upward by 58%. And this has been compared with the lung function test, where FEV1 was found out before and after bronchodilator. So FEV1 showed 16% reversibility, and small airway reversibility, as you know, is seen with lung function. It is only 15% with spirometry. However, with lung oscillometry, the small airway reversibility, which we look at 5 minus 20, is 75% and 79%. Almost 5 times better than what we get with the conventional spirometry. Now, what are the cutoff values? This is also a great challenge even today. So the cutoff values are said to be different for different parameters. For example, if I use thoracic impulse oscillometer, the values are slightly different than if you use V-wire or Indian machine iCaltech. All values are slightly different. However, I refer to these values, cutoff values, and R5, just roughly say 5.01, let us consider 5 is normal. If it is more than 5, it is abnormal. R20, large airway resistance, always look at that, 2.6 pascals per liter per second. And R5 minus 20, resistance of small waves, remember 1 pascal liter per second. And AX, area of reactance, which is the low frequency integrated impedance, reactance of 5 Hz and about a point of resonant frequency, has to be 10 pascals liter per second. So these are the figures which I have taken it from the largest and biggest study on COPD, and that is the ECLIPSE study, and Dr. Kelly was the chairman of this study. So I always refer to this. However, the ARISE has also done, and they have come out with the Indian impulse or lung oscillometry, where the R5 is 4, R20 is around about 2.5, R5 minus 20 almost same 1, and area of reactance, which is low frequency integrated, here it is 10. In Indian study, it was found to be 4. So this is also very important to know what is coherence. Coherence is correlation between airflow and pressure. So if there is mismatch, coherence will be below 6, and normal coherence at 5 Hz, which is equal to or it should always be more than 6, and at 10 Hz, it has to be more than 8. So coherence, look at the coherence in the graph that is given. And as you know that during doing spirometry, we can get zigzag graph or irregular graph, particularly for low volume loop, or if patient coughs, there are various notches in the flow volume loop. So we do not accept that graph. If patient has not blown for a 6 seconds, we also do not accept that graph. So similarly, looking at coherence. Why it happens is because the inability of subject to relax. Then at times patient hyperventilates. That's why the procedure must be explained to patient before that this is very simple test. This can be done within 30 seconds. And if there is leak around the mouth, we can get coherence which is abnormal, or improper bracing of the cheeks also can give rise to abnormal coherence. Then swallowing, particularly during tidal breathing, if patient swallows 2-3 times, then there is abnormality. Then tongue is obstruction in the mouthpiece and there is inadequate nose clips. So look at the coherence, and then if it is coherence is more than 6 at R5, then it is okay. If coherence is more than 8 at R20, then that is also normal. So now let us look at the bronchodilator test. It is similarly what we look at the spirometry, and we say that if FEV1 changes by 12% and 200 ml absolute increase in the value of air, we call good reversibility. Similarly, change in R5 by 30 to 35% and change in AX, sorry, this is not AZ, AX, the Goldman triangle, by about 30%. But some say 40%, some say 30-35%. So anything more above 35%, I personally report it as to be good bronchodilator airway. In bronchoprovocation test, the increasing R5, R20 and resonant frequency with the decrease in X5. X5 is the only parameter sensitive to detect bronchial hyperreactivity, that is 20% reduction in FEV1, well correlates with the 50% decrease in X5 in inspiration. So that is very important. And this is what Dr. Sandeep Savia and Bailey has done it in Indian studies. Now, resonant frequency is the value of Hertz at which inertia and peripheral capacitance of lungs have equal values. At this point, total reactance becomes 0. For adult, it is 7 to 12 Hertz, higher in lung disorders, both restrictive as well as obstructive disorders. And AX is the area under curve or Goldman's triangle from the lowest frequency to resonant frequency, which is increased values are correlated with distal obstruction. So resonant frequency, what it is, you just imagine that you are inflating a normal balloon. So you are inflating. A point comes when the pressure in your mouth and the balloon is equal. So that is 0 respiratory frequency. But if you start blowing the balloon of football, you require to generate more and more pressure to inflate it. And that's why that is because it has got higher, they are quite thick and they offer you a lot of resistance. And that's why you get the resonant frequency which is shifting from left to right side. Similarly, when you view bronchodilation, the respiratory frequency, if it shifts from right to left, that also can tell us whether there is good bronchodilation or not. Now, what are the advantages over conventional spirometry? Very easy to perform with tidal volume. Time required is 30 seconds. Preschool children and very old people, 70 plus, can perform it very comfortably. Major impedance, that is mechanical properties of lung, which is resistance as well as reactance. In doing spirometry, we don't know what is the reactance, but here we can definitely know what is the reactance. And monitoring the progress of airway obstructive disease, repeat variability 10% against that of spirometry, that is 5%. So best for small airway measurement, which is more sensitive, can be performed in pregnant patients also, particularly in last trimester, patient has breathlessness, and then we have to rule bronchial asthma. We cannot perform spirometry in the last trimester of pregnancy. However, this can be done in pregnant patients because it is a just tidal volume that patient is breathing in the instrument. And it can be done with where spirometry is contraindicated, such as repeated pneumothorax and acute myocardial infarction. So even with acute myocardial infarction, we should not perform spirometry for at least a couple of months, but impulse oscillometry or lung oscillometry can be done within a week also. Now, these are the cutoff values. This is particularly important, particularly if we are treating COPD. Say baseline impulse oscillometry, again, that has been taken from the ECLIPSE study, where Dr. Kelly has been a pioneer investigator, he was also chairman of Gold Committee. And if you look at all these parameters, the most important parameter you must have realized is AX, that is Goldman triangle. In COPD, it was quite high. The normal individual was 3.8. Here in COPD, combined all stages, it was 9.9. And as the stage increases, the AX value also increase. So for COPD Gold 2, it was 13.7, then 3, 22.5, 32.3 for Gold A. So look at AX values particularly in COPD patients. Let us consider the interesting cases. I have some interesting cases in which adults and also pediatric cases. So this is a female, almost 50-year-old. She has bronchial asthma for 5 years, but she was not aware at all. Her main complaint was cough, cough, cough for almost 2 years. It used to be more in the night. And most important clue we got in her history that the father has asthma. So we did impulse oscillometry. You see that airway, large airway, which indicates R5 reversibility is 48%, R5 minus 20 reversibility is minus 77%. Excellent. Then AX, Goldman triangle, has improved by 70%. And this is nothing but a typical case of cough variant asthma. Now, okay, we'll go where both the tests are done. So both the tests are done on a female 63 years and bronchial asthma for long-standing 12 years of asthma. Here you see the spirometry is normal. The FVC is 97%, FEV1 is 140%, 14%, while there is no significant reversibility. But if you look, patient has symptom, if you look at the impulse oscillometry or lung oscillometry, the R5, large airway, there is 26% reversibility. R5 minus 20, small airway reversibility is more than almost 50%, that is 58%. Similarly, the reactance line has become positive, that is the good reversible small airways. AX has also improved by 52%. So this is a typical case of small airway asthma, what we call as SAD. This is an interesting story. This is a male, 66-year-old. He had dyspnea for last 6 months. And this is in the era of COVID. So he was seen by another chest physician in 2020. And then with the examination, he had definite clubbing. Then he had basal cracks, which are very typical of ILD, exertional dyspnea, which is very typical of ILD, and then he got the CT scan done. However, still the patient was not relieved and he came to me. And then we thought, let us do impulse oscillometry. And what we found that this patient not only has ILD, but he also have good, significantly reversible airway disease. The large airway, small airway, say 48%, 55%, and Goldman triangle AX, all they have almost improved more than 50%. So this patient has both. We have put him on inhalation therapy with budesonide and formoterol, and he showed excellent relief as far as dyspnea is concerned. So this patient has ILD with bronchial asthma. As we know that we can see hypertension and diabetes in the same patient. Similarly, even if it is ILD, if patient is not showing good response with your treatment, then always perform the lung oscillometry, which can definitely give you some clue. So this is ILD plus bronchial asthma. Now this is 67-year-old bronchial asthma for last almost 20 years. If you look at again here, FVC is 63%, FEV1 67%, means she has moderate asthma and there is no good reversibility with spirometry. She has done spirometry well because she has blown almost 6 seconds and we can pass this spirometry to be normal. However, when we do impulse oscillometry or lung oscillometry, we can see significant change in small airways, which has improved by 45%, and AX almost improved by 48%. So take home message is that you perform both the tests. The chronology of test is first do impulse oscillometry and then do spirometry, that is pre-bronchodilation, give bronchodilation, either 2 puffs of levosalbutamol or salbutamol, and then perform impulse oscillometry first, followed by spirometry. So that has to be chronological order. So this is again a case of chronic bronchial asthma. She needs still inhalation corticosteroid and budesonide, which we have continued on. Now this is 38-year-old female. PFT does not show reversibility, though she has chronic bronchial asthma for 6 years. And if you look at FEV1, FVC, they are almost normal, 89, 87%. But here you look at the reversibility, particularly with impulse oscillometry. Small airway reversibility is 73%. Large airway reversibility is almost 44 to 45%. And even AX has improved by 72%. So this is total airway reversibility. This patient has large airway obstruction. This has small airway obstruction, as well as she has reactance which improved very well with bronchodilator. So the lung function may not give you clue because we have all the parameters which have been standard set are not showing good reversibility. Here we get excellent reversibility. Now, similarly, this is male, non-smoker COPD, particularly he has COPD for last 12 years. Look at FEV1, FVC. Yes, in spirometry, it is suggestive of airway obstruction, that is FEV1, FVC, less than 55% even after bronchodilation. And there is no improvement at all. Similarly, when we perform the lung oscillometry did not give a significant improvement in the small airway, though there is some improvement, 30% in small airway. The lung reactance here, AX, is 53. That is almost 5 times more than the normal, and which has become 57. So there is fall in AX by 8%. So though both of these, spirometry as well as impulse oscillometry, they correlate very well with each other, proving the diagnosis of COPD, which is stage 4. Now here, this is a female, 73 years old. She has COPD for 13 years, and PFT is not acceptable as she has not blown for 6 seconds at all. Look at the flow volume tube, they are also very small. But here, considering the age, the impulse oscillometry or lung oscillometry shows good reversible, particularly peripheral airway disease, as well as large airway reversibility is also seen. And most important is the AX, basically it was 144 before bronchodilator, has come down to 95. So there is 34% improvement in these small airway reactance and resistance, which fairly correlates with COPD. So you can diagnose this or label this as COPD with good peripheral airway improvement in reactance. Now, this is a female, 47-year chronic bronchial asthma. PFT shows evidence of COPD. FEV1 predicted shows FEV1 FVC 56% post bronchodilation. But there was no improvement as far as change with bronchodilator is concerned. Here it shows significant improvement with the small airway more than 30%, that is 33%, as well as you look at the AX parameter. Initially it was 198, it has become 86, that is 55% improvement in small airway obstruction. This is a good case of chronic asthma which is going in the COPD. Though this spirometry says COPD, still we can say it is chronic asthma showing good result with bronchodilator reversibility, and that's why this type of patient should be treated intensively with ICS and other bronchodilators. Now coming to next case, this is male, 62 years, bronchial asthma for 8 years. If you look at reversibility again, this is a case of mild asthma. If you look at spirometry, there is no significant improvement in FEV1. Here, the impulse oscillometry again shows that total reversibility, R5 has improved. Then the R5 minus R20 has significantly improved, 85%. And AX fairly correlates with the reversibility of airways. Here, the AX, which is before bronchodilator, is 28.54, which has come down to normal, 5.36. So this is a bronchial asthma with excellent total reversibility. Now this is female, 46 years of age, bronchial asthma for last 6 years. And if you look at PFT, FEV1 or FVC has improved by 17 and 15%. However, if you look at the absolute amount of reversibility with the FEV1, before bronchodilator it was 9.93 and after bronchodilator it was 1.08. Means there is only improvement in absolute value by 150 ml. So considering these 15 or 17% bronchodilator values only should not be considered. We must always consider increase in absolute value. Here, the patient's FEV1 has improved by 150 ml. So still we will not call, though it is labeled as good reversibility, still I will not call it as a good reversible airways. But the lung oscillometry shows excellent reversibility, small airways. Well, we look at R5 minus 20, it is improved by 50%, and AX by almost 49%. So that is the great advantage of doing impulse oscillometry or lung oscillometry. Now this is 65-year-old, COPD 10 years. She has given excellent expirograph, which is she has blown for almost 8 seconds with a small flow volume loop. And similarly, the lung oscillometry shows evidence of COPD, and there is no good reversibility either in spirometry or impulse oscillometry. Look at AX values. 108.505 is almost 10 times than the normal. The resistance and reactance particularly, which has increased, in fact, 124% after giving bronchodilator. So this indicates that the patient has COPD. Here, same. The male, 57 years old, ex-smoker, COPD shows good reversibility. In fact, FVC has improved by 70%. FEV1 has improved by 37%. But this is at low lung volume. Look at the FEV1. It was 0.26 before and 0.36 after bronchodilator. So the absolute value improvement was only 110 ml. Though the actual percent shows good reversibility, ideally this graph does not show good reversibility, but that also is true with no good reversibility with lung oscillometry. See, AX has improved by 20% and small airway 5 minus 20 only 1%. So this fairly both for the graphs correlate. They are like they are very well, you can take it as COPD only. This is male 61-year bronchial asthma for 8 years. PFT showed excellent reversibility, which is 40% improvement in FEV1. Look at the FEV1 1.03 before bronchodilator, which has 1.55 after bronchodilator. Yes, there's significant improvement. FEV1 improved by more than 200 ml and more than 12%. Good reversibility. And here, look at the lung oscillometry, through and through reversibility, large airway, small airway reactance has also improved, AX by 57%. So, but this type of patient is walking towards COPD. Mind well, you look at the R5 minus R20, normal it has to be 1. It is 3.9 before and 1.68 after bronchodilation, but still it is more. And look at AX values, 125, which has become 54.9. Reactance has also improved, but he has higher reactance than compared to normal. So treat him intensively. Now this is bronchial asthma, 9 years, female. Bronchial asthma for 9 years and 70-year-old female asthma. PFT again shows does not improvement in lung function. However, impulse oscillometry show through and through total reversible of large airways, small airways, even small airway reactance has improved. And then is it artifact? They look at the coherence. Coherence at 5 was 0.87. That was more than 6. So coherence is normal and we can report this as excellent reversible bronchial asthma. Now COPD stage 4, male 72 years, ex-smoker, and he smoked for 272 pack per year. Here the bronchodilator, particularly look at low lung volume. Though we got 11% improvement, absolute value, there is no reversibility, but in lung oscillometry also, there is no significant change in the small airway or large airway. So that fairly correlates with your spirometric diagnosis of COPD. This is cough for last 6 months, male 21 years. Lung function test or spirometry is normal, but the lung oscillometry shows excellent reversibility. Large airways are reversible only 15%, but small airway 78%, and look at AX also has improved by 52%. So this is again a cough variant asthma. This person had a cough which was predominantly at the night, particularly midnight, and he had more symptom early morning also. This is again cough for 1 year, and this is bronchial asthma, particularly female, 21 years. Lung function test is normal. Look at FEV1, 10% improvement, no absolute improvement in FEV1. But here, look at the small airways, 232% improvement, and also X improved by 48%. So this is totally reversible asthma, and this is again cough variant asthma. She had sound sleep on day 1 when we had put her on budesonide and formoterol combination. Now let us find out some pediatric patient. Our youngest patient is male, female child, 3.2 years of age. And the features are typical of asthma. She had bilateral bronchi, running of the nose, family history of asthma. However, pediatricians are not confident as far as their diagnosis, or they are confident but they're not confident to tell the parents that your child has asthma. But with the lung oscillometry, when we did, we confidently said that she has asthma and she will also improve, and improvement will be excellent. So this is the small airway asthma, particularly in childhood. Now this is male child, 11.4 years. Spirometry is not acceptable, and the child has not blown for more than 3 seconds, and there is no good reversibility on PFT, but lung oscillometry showed significant improvement in AX, which is 23, which has come back to 8.55. So this also we reported as asthma. Now, this is a male child, 13.1-year-old, and PFT showed good reversibility. If you look at the FEV1 in spirometry, 1.36 becomes 1.57. So more than 200 ml, yes, 22% reversibility. Here also, small airway have improved to 62%. Even the AX is 62% improvement. The AX before was 54 and after it came out to be 20. So excellent reversible airways, and that is the asthma. Now this is a male child, 15.1 year, duration of asthma 1 year. The PFT is totally normal. Lung oscillometry show excellent improvement in small airways as well as on AX, which was 23 before and then almost 10 after bronchodilators. This is again in favor of a bronchial asthma. This is a female child, 3.9 years, showed excellent reversibility with lung oscillometry. The PFT is not acceptable as she has not blown for more than 3 seconds. And look at the flow volume loop, which is very small. So PFT not acceptable? Yes. Lung oscillometry is acceptable. As you know that coherence at R5 is more than 0.7. That's why it is more than 0.6. So this is the acceptable lung oscillometry graph, which shows bronchial asthma. This is male child, 6.4 years of age. Similarly, the PFT could not be acceptable as the small flow volume loop, and even though there is improvement by 13%, 11%, but you are confident clinically, and this type of spirometry, you can definitely treat as patient having asthma. You will get more confidence when you start doing lung oscillometry in such type of patients. We show excellent relief with bronchodilator, small airway improved by 64%, and the lung compliance improved by 25%, and this is nothing but bronchial asthma. Now this is male, female child, 9 years. Now this PFT shows good reversible airways, which is proved by doing lung oscillometry, which also shows excellent reversibility. So both are complementary to each other. And this is male child, 6.7 years. PFT shows good reversible airways. The FEV1 from 0.78 has become 1.04. So improvement is almost good reversible airways, but the bronchial asthma, male child 6.7, lung oscillometry shows excellent reversibility. So again, complementary to each other. So that's all. Thank you. So if you have any questions or you have any graph you want to, kindly please project it. I will be very happy to share.
Thank you, Dr. Bhadra. So I request the technical support team to allow access to all the participants so that they can unmute themselves and ask any query related to the presentation that sir has done today.
Sure, sure.
Arvind,
Yes, sir.
kindly allow access to all the participants to unmute themselves.
Yeah, already given, sir.
Okay. So I request all the participants that if you have any query related to the presentation today, please post your queries by unmuting yourself, and you can ask directly to our faculty, Dr. Bardha Purkar.
Hello.
Hello, go on.
Yeah, am I audible?
Yes, yes, yes.
Okay. Okay. I'm Dr. Arnal. I just joined this meeting late actually.
Okay.
I used to perform this oscillometry, but not. I don't usually do this pre and this post bronchodilation. I only just do it once. So actually, so today I'm hearing it for the first time. So regarding this thing, the pre and the post, this timing, is it the same like spirometry? Like we have to wait for 15 minutes,
Yes, yes.
as you mentioned?
And the chronology is do first impulse or lung oscillometry and then spirometry.
Okay.
Spirometry after pre-impulse. And I don't understand why you are not doing bronchodilation test with impulse oscillometry or lung oscillometry.
Like we used to do it with the spirometry, and like according to the guidelines, we have this about for especially for the bronchial asthma. We used to have like the changes in the FEV1 like more than 200 ml.
We will
So
get
we have some criteria. So is there any criteria for oscillometry? Because I have very less idea about it.
I told you, no, 35% improvement in R5-20 or
Okay.
improvement by say 40% in AX values after bronchodilation. And that is
Okay.
as
So so 35% in this R5, right?
yeah, right. And that is what I was telling, that it varies from instrument to instrument. Some says that
Yes.
improvement 30% we consider good bronchodilation, some say that 35 to 40%. But remember these 6 important parameters as I showed you. R5 indicate total airway resistance, R20 large airway resistance, then R5-20 small airway resistance, AX, that is the Goldman triangle, indicate reactance and resistance, particularly small airway disease, X5, which is more negative and show very important in finding the COPD severity, and look at the resonant frequency. Normal resonant frequency will be between 7 to 12. It is the point where the reactance line crosses the central line. Okay, that point is called as resonant frequency. If resonant frequency is 20 pre-bronchodilator and it becomes 12 after bronchodilator, that also shows significant reversibility of airways. So look at R5-20, R5 resonant frequency, look at X5, look at Goldman triangle. So these are all the 5 things which 5 or 6 things you must keep in your mind. And don't forget to look at the coherence. Coherence at 5 Hz has to be more than 6. Coherence at 20 Hz to be more than 8.
Okay, thank you.
Hello, good evening, sir. Sir, this is Dr. Poddar.
Yes, yes. Please go
Sir,
on.
please explain coherence again, sir. Coherence.
Coherence, we get abnormality in the impulse or lung oscillometry. And the coherence, basically what we have in PFT, patient has blown and then stopped, then blown, you will get a notch on expirograph or flow volume loop. And patient has cough, you will get seesaw graph. So that is not acceptable. Okay?
Yeah.
The graph has to be very smooth, the flow volume lung has to be very smooth. Similarly, when patient is under stress, patient is putting tongue to the mouthpiece, then
Yeah.
patient has cough. These are all the things which will give you the coherence.
Yeah.
Coherence at 5 hertz. If it is less than 6, coherence at 20 hertz, less than 8, then you should not accept, but hardly, rarely we get it. But you should not accept and you should repeat the test. So coherence is a indication whether you have to accept the graph, lung oscillometry or the impulse oscillometry, yes or no.
Thank you, sir. Excellent presentation, sir.
Thank
Excellent presentation. Congratulations, sir.
Thank you. You are from Ichalkaranji or Kolhapur?
Yeah. The other day I talked to you, sir.
Right. How was your presentation?
It was nice, sir. I will send you my presentation on your mail, sir.
Sure.
You just give me suggestion. Okay, sir. You had an excellent presentation today and well explained to everybody, sir.
Thank you.
Thank you, sir. And the examples were all good and explanatory well, sir. That has understood the subject, sir.
Thank you very much.
Thank you. Congratulations once again.
Thank you.
Sir, good evening. Sir, I'm Dr. Prahlad Daima from Sikar, sir.
Pardon?
Sir, I am Dr. Prahlad Daima from Sikar, Rajasthan, sir.
Oh, okay. What is your question?
Sir, in oscillometric graph, there is depicted upper limit of normal and low limit of. Is there any meaning of that, sir?
See, we look at the cutoff values, particularly impulse oscillometry, because it has shown in Indian study by Dr. Sandeep Sarvi that they do not look at the predicted, because they look only at the cutoff values, because they do not change very much, particularly in children and adults. So cutoff values are for R5 is 5, that is total airway resistance. R20 is 2.6. R5 minus 20 is 1. Then AX 10. And resonant frequency between 12 to 7 to 12. If R5 is more than 6, yes, large airway problem. If AX is more than 100, yes, this patient may have COPD. So look at the cutoff values and look at the cutoff value, particularly post-bronchodilation, as we look at FEV1 or FVC in spirometry.
Yes, sir. Thank
Hello,
you, sir.
sir. Hello, sir. Good evening. I am Dr. Balani from Indore. It
Okay.
was really very excellent presentation. I am also doing this Tremoflow at my clinic
Very good.
regularly.
Very good.
Something I want to add on, that the posture of the patient is also very important, because when patients are doing a test with a flexed neck, they usually have an obstruction that
भैया,
sometimes give
आ रहा है?
obstruction. And
No, I didn't find any much. Just 15 degrees slight extension.
extension, that is
That is all.
that is
does-
very important. Yeah, yes, sir. And sir, what is the role of a CV value? Because coefficient of variation, that is also because CV at 5 we always take for the standardization of the test.
The coefficient of variation, that is CO, look at R5. It has always to be more than 6. Look at R20. The coherence of should be more than 8. 6 and 8, these are the values. If you are expressing per ml, then that becomes 0.6 and 0.8, right? So look at the coherence, they are normal, then that graph is acceptable graph. That is that simple, very simple.
Now, as we do this test, can we grade asthma also, as we can grade asthma from a spirometry? Can we do grading step 1, step 2, step 3 like that also?
No, but actually we can predict, because what spirometry has given us for years together, look at FEV1% predicted, right?
Right.
If it is less than 60% of predicted is asthma, this is severe asthma.
Severe asthma. Yeah.
More than 80%, this is mild asthma.
Yeah.
But here, we cannot grade it like that. Similar is case with COPD. However, the ECLIPSE study I showed you, as far as
Yeah.
COPD, the COPD has stage increases from stage 1, 2, 3, 4. The AX value goes on increasing. But
Okay.
a day will come where we can say by looking at lung oscillometry that patient has stage 4 COPD or moderate asthma. But all in these cases look at AX values because that is most important as a reactance parameter, which
Yeah.
is quite high in COPD patient and in
Showing
some
smaller.
patients, some asthma patient also are quite high. So probably these are the patients which may go in COPD in later life. And it is rightly said, almost 20% of asthmatic in their whole life, they enter in COPD. So 1 out of 5 asthmatic will have COPD in their life.
So, sir, according to present status, as we are having a role of spirometry in GINA guidelines, is there any role of this test in GINA guidelines so far as management is concerned? Because we are giving one ICS LABA plus LAMA. So, can we, according to the FOT, we can decide according to that, or we can give only ICS LABA only?
See, the problem is that there are different types of machine, like V-Wire, then the Thoracis, Indian Caltech, and so many more. And they have got their own predicted values, so they vary. Now, this I have discussed with Dr. Sandeep Savi in the latest meeting which we had at Pune, and he said that at an international level, there is an organization where we are going to sit and find out the normal values or the most important are they have to be same as far as the multiple instruments is concerned. But that is not a simple job. So the spirometry, yes, we can definitely say that patient has restrictive, obstructive, mixed pattern, but the impulse oscillometry is going to give you a lot of problem because when I started, we are doing it for last 5 years, thoracic. And what we found, almost 70% of the patient has small airway asthma. That is R5 minus R20 has significant improvement. And we are, in many patients, we are putting them on Nivioli inhaler. This Nivioli inhaler has a particle size of 1 micron with beclomethasone and formoterol combination. And patients are showing good response. And at ARISE Pune study, we are also contributing small airway asthma, and in near future will come out of that.
One last question also. What will be the pattern in a restrictive lung disease?
In restrictive lung disease, okay.
Yeah, sir.
Basically, if it is restrictive, R5 will be normal, right? Because large airway. R20 will be normal.
Yes.
R5
Definitely.
minus 20 may be raised as what we get in COPD, early COPD, right?
Okay. And
Small,
what about AX value? That will also remain normal. So it will be essentially a normal type of test.
yes, but the reactance AX is improved, shows abnormality, significant abnormality with AX. And how to differentiate it from the COPD and ILD? Particularly
Yes,
in ILD, X5 in inspiration is more as compared to X5 expiration. X5,
Right.
which is exactly reverse in COPD. However, in many cases, I get mixed picture, but just look at AX values, that is reactance and resistance. If they are raised quite high, say 50, 60, but R5 is normal, R5 minus 20 may have some change. I will call it restrictive lung disease. Like for example,
Okay.
bronchitis also. With spirometry, we get exact almost normal, but in
Indeed.
bronchitis, AX values will be raised.
In other words, we can say that X value usually signifies there is air trapping.
Yes, small airway, reactance and resistance. So when
good.
your compliance is reduced, particularly in COPD, early COPD, X are
Yeah.
factor only.
Right, sir. Thank you very much, sir. But really, it was really very eye-opener presentation from your side. We are really appreciating your lecture. Sir. Thank you very much, sir.
Thank you.
Thank you. Sir.
So if there is no more questions, so I would like to ask our zonal sales manager Om Prakash Yadav for closing remarks.
Yeah, thank you, Vikramji. So, good evening, all doctors. On the behalf of Lupin Spiritus team, I would like to extend my heartfelt gratitude to our esteemed speaker, Suhas sir. Suhas sir, thanks a lot for taking the entire session and the lovely presentation. The feedback which is already has been shared by Dr. Poddar sir, and it was super presentation. They have got some insight also, and the case-based discussion which you have done, sir. I sincerely thank you for taking the efforts to prepare and give your time in your busy schedule. I also sincerely thanks to all the doctor participants who have taken out the time from their busy practicing schedule for this evening and making this event successful. We look forward from on behalf of Lupin Spiritus team in future also for doing such academic meetings. And thanks everyone for joining this meeting and have a great evening. Thank you, sir, again on behalf of Lupin Spiritus.
Thank you.
So I request the admin team to please close the meeting.